it's amazing to work with surgeons who know both ends of it and who can really relate it in a lay language where everyone, including myself, can understand. In LA, it's really difficult because I go to parties and I always say like, oh, I work with the best surgeons. They're great. And then I get a bunch of people around me. And then they say, well, okay, well, what do they do? Do they do cosmetics or injectables? And then when I say no, they're gone. But truly, the ability to work with surgeons who understand all of it is phenomenal and important. What I couldn't do is allow Dr. Ferries to have the best talk or the best surgical talk here. So I brought in a ringer, and that's Dr. Gangi. Dr. Gangi joined us from Moffitt, where she trained classically in surgical oncology and melanoma surgery, and has been with us now 5 years. It seems like just yesterday, but is really an example of how surgical oncology has changed, not just for big surgeries or for early surgeries, but also to help us to get our patients from treatment to treatment to treatment in order to find the right therapies, and how we work at the Angeles Clinic for our trials along with our major partner, Cedars Sinai Medical Center. I will say Dr. Ferries put up MD Anderson and the NIH, and we're much smaller, but this is a model for every place throughout the United States. Those people that used to fly in from Nebraska can get this in Nebraska. Those people who used to come from Las Vegas can get this in Las Vegas and can stay at the Encore overnight. So it's available for everyone, even in a place like this that's small and compact, and about 30% of it is cafeteria. So with that, I'm going to invite Dr. Gangi to talk to us about surgical therapy in melanoma.
Thank you for the kind introduction. Dr. Hamid lied, and he actually brought me here so Dr. Ferries could look even better, but I'm not even sure that's possible. So my job is to talk to you about surgical therapy for melanoma, novel paradigms. I have no financial disclosures. I will say, in attempting to make this talk, the first version of the talk was that I wasn't talking about surgery at all, and that's probably the novel paradigm, is that we're doing less and less of it. So it's been revised really to focus on surgery. The other disclosure is that if Dr. Ferries considers himself a simple surgeon and not intelligent, then I have the intelligence of an earthworm. So with that, we'll kind of start broadly. Melanoma is known to be among the top 5 cancers diagnosed in the US. These are estimates from 2020. And you can see that in both males and females, there are still high rates of melanoma. The 2022 ACS incidence predictions were that we would have over 2,000 new cases of melanoma predicted for the year 2022, split fairly evenly between non-invasive, meaning not having the ability to spread to lymph nodes because they're fairly early, and invasive cases. And over 11,000 of those cases predicted for the state of California. So we're very fortunate to have people like Dr. Hamid, Dr. Mamie, and Dr. Ferries here in our own backyard to treat these newly diagnosed patients. And really, it's the highest number of cases of any state, followed by Florida and Ohio. So again, my goal is to talk about the evolution of melanoma treatment from a surgical standpoint. So for that, we always require a little bit of history. And it was really very long ago that the first recorded of melanoma was predicted from the 5th century BC. And the word melanoma was derived from the Greek mela, black, and oma, tumor. And it really wasn't until 1787 where we had information about the first surgical removal of a recurrent melanoma of the jaw from a young male. So we did know about melanoma long ago. And in the late 1800s, it was Herbert Snow who first advocated for excision with prophylactic lymph node dissection, meaning we were doing very big surgeries and essentially removing huge chunks of tissue in addition with lymph nodes. And In the late 1960s, we finally devised a scale for determining thickness and what kind of surgery may be useful for patients. So we've gone from aggressive to less aggressive, but we'll talk about that a little bit more. So typically when I see a patient with melanoma in my office, my goal, and I fortunately work with very good dermatologists and physicians who refer to me. So a lot of this work has generally been done for me before I see the patient. But the question is, do patients have symptoms or distant disease? We do a physical exam looking at the lesion and surrounding pigmentation. This image here is typically not what I see because usually this is what the dermatologist sees, and usually there's been a biopsy of this particular lesion, and that's why they end up in my office. But if this were to exist, then this is a suspicious lesion that should be biopsied for a variety of reasons. And then if they come to me with a pathology report, then I look at things like the thickness, concerning pathologic features, like is there ulceration or there significant mitotic figures, and then the subtype of melanoma, and that might determine whether they're eligible for surgery. And typically, there's no imaging that's necessarily done unless we know that the patient has bulky disease elsewhere. And again, typically those patients don't present to their surgeon first. They'll go to someone like Dr. Hamid or Dr. Mamie, and our esteemed colleagues sitting here. So those patients will then be worked up appropriately with additional imaging if necessary. The reality is that most patients will actually present with localized disease. And what that means is disease is kind of limited to not yet having spread to lymph nodes or being distantly metastatic. And you can see that the 5-year relative survival rates for patients with localized disease is actually quite good. And it decreases as disease progression continues on. So when we're talking about localized versus non-localized disease, what does that mean? We typically we stage patients. So staging, you may have heard and you've been told you're a stage 1, 2, 3, or 4. And staging is based on 3 factors: the T stage, which is the tumor depth, the N stage, which is nodal disease, and then M stage, which is based on distant metastases. And these pictures here essentially just represent, depending on how deep the lesion is, that'll give us the determination of the T stage or the tumor stage. And if there are no lymph nodes or distant metastases, you're typically a stage 1 or 2. And this is an entire talk in and of itself with modifications that were made in the most recent 8th edition. So I'm going to focus first on the management of early stage disease, which is really where the surgeon fits for now. And we have not yet become obsolete. And the management of melanoma for early stage disease is that the primary lesion, so that site that I showed you earlier that the dermatologist had biopsied and then sent to me, is excised, and it's excised widely, and I'll explain what that means in a minute. And given that even these early lesions have a predilection for nodal spread, depending on the depth of that initial tumor, you may or may not be told that you need something called a sentinel lymph node biopsy. But the reason that we worry about these nodes is because nodal status tends to be most prognostic for survival, and it determines whether you're eligible for additional therapies. And a majority of patients, like I said, will present with no clinical evidence of nodal metastases, meaning when we're palpating your neck or your underarms or your groins, depending on where your melanoma is, we don't actually feel any big lumps or bumps that are concerning. So that means you have no clinical evidence of nodal metastases. That doesn't mean that there may not be micrometastatic tumor or tumors that we just can't feel in those particular regions. And historically, as I mentioned, the recommendation was to perform lymph node dissections, meaning we were taking out big packets of lymph nodes. We were doing the same thing for breast cancer. And I'm sure you've seen, if you look back in medical textbooks or pictures, people who have swollen legs or arms because they've had these very extreme nodal dissections. Some of that has improved just with our surgical techniques, but the reality is that that's a possibility. So we were doing big surgeries and realizing that only about 12 to 20% of patients actually had evidence of metastases with early stage tumors. And so, multiple studies have been done, and Dr. Morton, who's essentially the godfather of sentinel lymph node biopsy for melanoma, with whom Dr. Ferries worked very closely, and Dr. Ferries have modified the way we manage nodal disease and evaluation of nodal basins. So I'll go back to the nodal basin in a second, but with respect to wide excision of the primary, what that means is, again, you have the spot here on the top. And again, typically this has been biopsied. And depending on the depth on the biopsy, right? So we know if it's in situ, meaning early and lower preponderance from spreading into lymph nodes, thicker, essentially as you go down. Depending on the thickness of the tumor or the T, the surgery involves an excision of this particular thing. And from the very edge, we then measure out 0.5 to 1 or 1 to 2 centimeters, or an entirely 2 centimeter excision. So typically what I tell my patients, the reason you kind of see this eye is because skin doesn't tend to close up. If you cut out a circle, it doesn't heal nicely in a straight line. And so it typically requires that we create some kind of an oblique or moon-shaped incision in order to close that back up. But the reason for that is because there have been multiple studies that were done looking at how much adjacent skin we need to remove in order to get all of the tumor and limit the recurrence of disease. And that is why such a large chunk of tissue, adjacent healthy tissue, is taken. Obviously, for this patient, that's much more significant. So if this patient presented with no clinically positive nodes, this is someone in whom what Dr. Patel talked about with neoadjuvant therapy, this is someone we may consider for that, or other injectable therapies that I'll talk about in a moment, to kind of minimize the extreme of surgery for having to remove that area. With respect to nodal status, I had mentioned Dr. Morton. So he was the first to report on the sentinel lymph node biopsy as a less invasive technique to evaluate nodal basin status. And essentially what that involves is you have your primary melanoma here. We inject some blue dye and some radio tracer, which allows us to count radioactive uptake essentially in the specific lymph node basin. Because you can imagine if you have a melanoma, let's say smack dab in the middle of your back, right? So you have multiple nodal basins that are potentially draining that area of skin. It may go to both your underarms, it may go to both your groins. And if we treated this historically and said, okay, well, let's just cut out every potential lymph node basin that may have tumor within it, we're cutting multiple different sites for potentially limited benefit. So the sentinel node biopsy allows us to inject peritumorally, meaning where that tumor is, and then modern day, you go to X-ray essentially, and they're able to see where the uptake of that radio tracer is. And it might say, well, this particular spot in the middle of your back drains only to your left underarm or to your right groin, or potentially both. So it gives us some direction in terms of where we need to go. And then at the time of surgery, we inject some blue dye peritumorally. And in using essentially a counter, which picks up that feedback, the radioactive feedback, and using our vision, it allows us to make a very small incision and pull out the first lymph node in kind of that echelon of the draining lymph node basin. And the thought there is if the tumor had spread from this primary site, it's most likely to go to this first node before it drains to any of the other ones. And so by removing this one that has the highest uptake and the most blue dye, it should give us a representation of if you have additional lymph nodes in that particular basin. And the MSLT-1 trial, which is one that Dr. Morton performed, essentially suggested that if patients had a positive sentinel node, that they benefited from having a completion lymph node dissection. But the reality in looking back at that data was it didn't really seem to improve overall survival significantly. And so then Dr. Ferries and colleagues further studied that. And now we feel that we can actually watch patients who have a positive sentinel node with ultrasounds, and we may suggest additional therapies. So again, the evidence-based guidelines for sentinel node biopsy are in patients who have very, very thin tumors. No sentinel lymph node biopsy is recommended, or melanoma in situ. And then in other patients, we essentially recommend sentinel lymph node biopsies. If you come in with clinically positive nodes, from a surgical standpoint, historically, we would recommend a complete lymph node dissection. Currently, given the number of therapies that we have available and how well they work, there are a slew of other options. So that's just something to consider. But since I'm a surgeon, I'm telling you what surgical guidance is. And then so standard nodal management based on these randomized trials, essentially, if you have a positive sentinel lymph node, and this is based on MSLT2 data, generally we'll follow those patients with close observation and ultrasound every 5 years. For 5 years, every 4 months for 2 years, and then 6 months for 3 to 5 years. And if those patients have recurrences, we can certainly move forward with a completion lymph node dissection. For patients with clinically palpable lymph nodes that are limited to a particular lymph node basin, again, we recommend complete dissection for those subset of patients, and we may or may not offer adjuvant immunotherapy or targeted therapies for patients with nodal metastases. And Dr. Ferries, I agree with you. My colors are all messed up too. So for these early stage patients, what are new paradigms or novel paradigms? Well, certainly we're doing more and more minimally invasive surgery, which involves laparoscopic operations or robotic operations, particularly in the area of groin lymph node dissections, both for superficial and deep lymph node dissections in the groin. We can perform these videoscopically. I didn't post actual pictures because typically patients don't always like to see that stuff. So here are cartoon images of how we may do that. We essentially put in some trocar sites. We can essentially put some CO2 in that area, which allows us to see better. And then you're dissecting on the same types of structures that you would be dissecting on open. But at the end, instead of having a large open incision, you essentially have a few small incisions and a drain. And the patients tolerate this significantly better. Similarly, for robotic surgery in the deep pelvic space, this is something that we can do. And then in the setting of patients who may qualify for resection of their metastatic disease based on limited progression of disease or really good responses, those are things that we can perform, again, less aggressively. So this is supposed to say, what about low recurrent or locally advanced disease? But the considerations essentially for those subset of patients are the location, the number of deposits, the previous excision to clean margins, whether the patient had received any previous treatment and what comorbidities patients may have. So in advanced patients, we generally recommend a multidisciplinary discussion and shared decision-making between essentially medical oncology, surgical oncology, and the patient in order to determine what might be the next best treatment paradigm for you. With respect to local recurrence, so this is a patient who had a previous excision. You can see here, the surgeon did a nice job closing this in a straight line, but this was a local recurrence. And this patient had no additional disease or recurrent disease elsewhere worked up. So in this patient, you can certainly recommend therapy, but we also have the option of just excising this particular area with 1 centimeter gross margins. And there have been studies that have been done retrospective in nature, meaning we look back at patients we have treated this way and found that, there are a significant number of patients who may have no further progression of disease. After this comes out, about 19% of patients will have no further progression. And at a median follow-up of 39 months, that subset of patients had no progression in about 77% of them. Some patients will develop recurrence. It may not necessarily be a local recurrence. It could be a distant recurrence or a regional recurrence, meaning to your particular nodal basin. And then some patients will have recurrence of distant disease. What do we do with sentinel nodes in those patients? There's really no good data to suggest that we should repeat sentinel node biopsy in those patients. So again, there's no increase in overall survival, but there may be a slight difference in disease-free survival in those subset of patients. What about patients who have essentially multifocal disease? So again, Dr. Ferry showed a similar picture in a patient who had been treated with BCG, but you could see there's multiple sites of recurrent disease in this chest, and then here in this leg, here in the scalp. So we have numerous intralesional and topical therapies. Dr. Ferry spoke about BCG. One that we use more commonly now is T-VEC or telimagin leherparepvec or Imlygic, which is an injectable herpes virus, which essentially you can inject into a select number of tumors. Typically, we'll pick the largest ones in a patient who may present with this pattern of disease. And the thought is that the herpes virus can selectively replicate and lyse the tumor cells, and then it actually promotes release of GM-CSF, which can stimulate your immune system to essentially kill some of the adjacent tumors. And in a fairly large study that was well tolerated, there's an about 80% response rate with 50% complete responses and 30% partial responses with 40% durable effect. And then I don't know why the text on the bottom isn't showing up, but these are topical therapies like Aldera that Dr. Ferries had also mentioned, which have fairly good efficacy. And you can see that this patient had essentially almost complete resolution of his disease. You can imagine that trying to surgically remove this would be quite aggressive, potentially with no benefit, and require a big free flap. Some other areas of treatment for someone who may have this pattern of disease in an extremity, especially the lower extremity, is hyperthermic isolated lymph perfusion. This was described in the 1960s. This is pretty aggressive. It essentially requires that we cut down in the leg to access an artery and a vein. And then we put some percutaneous catheters in there, and we treat you with chemotherapy melphalan, which is a very, very old chemotherapeutic drug, which derives from nitrogen mustard and TNF in Europe. And then we heat essentially the leg off. There's a tourniquet that's placed in the upper edge. And the thing to take away from this is it's possible we do have some responses of this particular tumor, but if you're potentially given the option of immunotherapy or other therapy, you may prefer that to having your leg cut open with these catheters, and there's significant complications that can arise, including limb loss. As I mentioned, given that we're going to less aggressive types of therapies, from that we derived isolated limb infusion, or ILI, which is a less invasive version of the ILP. And essentially this involves us cannulating those vessels in the leg with small catheters. And again, it's hyperthermic, but not as hot as the ILP. There's still inflow. You cause some acidosis and hypoxia to that extremity. And again, we treat these patients with melphalan as well, with no TNF. In these patients, there was no limb loss and typically only grade 3 complications, which are still significant. So we usually grade complications from a scale of 1 to 4, 4 being most significant and, obviously requiring multiple additional medical interventions. 3 typically requires additional support medically, but not necessarily a significant intervention. So the differences between the two essentially are the most important. I think I would focus on, you have fairly comparable response rates of 44 to 60%. With ILP, you can only typically perform it once. If the patient had bulky nodes, you could do a concomitant node dissection. But again, this is for a very, very, very select group of patients, and typically now not something that we do as a second line or third line therapy. It's really, we have so many other things that are potentially beneficial. You've seen this slide before, and the reason that surgery is becoming more and more obsolete is because we have all of this stuff. And Dr. Patel had talked to you about certainly neoadjuvant therapy and trials, and we're looking forward to the data from SWOG 1801 and NADINA in terms of determining what the best sequence of therapy is for this subset of patients. The question again that comes to mind is, what are the adjuvant treatments for high-risk patients? And then what are some combination adjuvant and metastatic treatments where we may be combining multimodal therapy, which may include surgery. And here again, the therapies that we have currently available for us allow us to think more strongly about metastatectomy in areas that may be resistant to the therapies that we're providing. So this is a group of patients that were treated with checkpoint blockade. And again, you can see the overall survival for the whole group. In patients who underwent resection of their progressive lesions and were resected to no evidence of disease, the survival was obviously better. And so again, we have to kind of leave surgery as one of the options, but it may not necessarily be first line for advanced patients. In conclusion, the treatment of melanoma continues to progress with improvements in prognosis. There's many options for the treatment of locoregionally advanced and metastatic melanoma, including MIS options. Multidisciplinary tumor board and shared decision-making is really important. And as surgeons, we need to be involved in the evolving treatments beyond surgery specifically. So I tried to make this as surgical as possible, but we are becoming obsolete. So with that, thank you again for having me, and hopefully that was slightly educational.